Hello, my name is Dr. Ukiri Richard. I continue my podcast on basic cardiology. Today we are talking about terminal heart failure. A 48-year-old patient who has been known to have a dilated cardiomyopathy for 5 years and has an implanted CROT ICD complained about rapid worsening of his situation with dyspnea, New York Heart Association 3 to 4. He has therapy refractory edema and nocturnal autopnea. Additionally, he has repeated ventricular tachycardia that are successfully terminated with the ICD, but his life quality has been reduced. To optimize his therapy, he was referred to a heart failure special clinic. There is no other medical illness of note. He is married, he has 2 children, and he is a tax advisor. On physical examination, he looks thin with a BMI of 19.5 kilogram per meter square. His general status was reduced. He was pale, the neck veins were congested. There was prominent V waves as indication of relevant tricuspid insufficiency. Blood pressure was 85 to 60 millimeters of mercury. On long auscultation, there were vertical sounds with bibasal crepitations. Pulse was 95 per minute. The heart rate was rhythmic, but there were a lot of extrasystole and a hollow systolic murmur above the mitral valve with radiation to the axilla. There was also a third heart sound. Abdominal findings were normal. The patient had mild pedal edema bilaterally, and the peripheral pulse were palpable. My question now is, what are the clinical parameters that have unfavorable prognostic relevance to patients with chronic heart failures? Okay, if I can tell you, there are 1, underweight, which are signs of beginning cardiac cachexia. When you have resting tachycardia, anemia, hypotension, and recurrent cardiac decompensations. So that's good. Now my question is, what technical tests are you going to carry out? Well, I will do routine laboratory tests like foot blood count, iron, ferritin, that is to check for anemia. Also check for sodium, potassium, creatinine, urea to check for renal insufficiency, and liver function tests. Check for BNP or pro-BNP, TSH, and INRO. I will also do ECG to check for relevant bradycardia or tachycardia, atrial fibrillation, or wide QRS complexes. I will also do an echocardiography to check for ventricular and atrial sizes or dilatation, check for thrombus, check for valvular insufficiency and signs of asynchrony. I will do chest X-ray to check for the heart size, signs of congestion, effusion or infiltration. Then I will also control the signs, the ICD CROT function, to see the heart frequency profile, that is actually the heart rate profile, check for atrial or ventricular tachycardia, check for ICD therapy in the fast VT or VF zone. Okay, you just got your blood test, and apart from the pro-BNP that was 9,735, the normal limit is up to 180, other laboratory findings were normal. My question is now, what position does the biomarker BNP or pro-BNP have in terms of diagnosis and control of therapy of chronic heart failure? Well, the extraordinary role of BNP/pro-BNP during the first diagnosis of acute or chronic heart failure is generally accepted, and has been a stand pole has been implemented as stand landmark in the guidelines of treatment of chronic and acute heart failures. A raised BNP stroke or NT-proBNP may also be a prognostic marker, but until now it has not been proven to be used as a therapy guide in patients with chronic heart failure. Okay, your ECG has been brought, and now you saw sinus rhythm with atrial trigger and biventricular stimulation from the CROT ICD. In the echocardiography, which you just did, you saw an extraordinarily dilated left ventricle with a left ventricular end diastolic diameter of 82 mm and a left ventricular ejection fraction of 12%. There was mild mitral as well as a severe tricuspid insufficiency regurgitation, and the PA pressure was 50 mm of mercury. Now the chest X-ray has been done, and you saw an enlarged heart without signs of congestion. There were no infiltration and no effusion. You saw the CROT ICD with 3 electrodes in place in right atrium, right ventricle, and posterolateral coronary vein. So you went ahead and did the ICD check control, and you saw very many therapy, that is anti-tachycardia therapy, ATP, in fast ventricular tachycardia area. My question now is, could you tell me the important, relevant, evidence-based pharmacotherapy for chronic systolic heart failure in stage 3 to 4? Well, I can tell you that one. ACE inhibitors or angiotensin 2 receptor blockers, they have a level 1A recommendation. Beta blocker also has a level 1A recommendation. Aldosterone antagonists have level 1B. Diuretics level 1C. ICD-CROT level 1A. Digoxin has level 2A to B in sinus rhythm. So that's good. Now you are talking about pharmacokinetics. I would like you to tell me the importance and side effects of this pharmacotherapy you just mentioned. Now let me start with ACE inhibitors. ACE inhibitors, they improve prognosis and they are basic therapy for heart insufficiency. In patients that were not hitherto therapied, the heart failure therapy should be started with an ACE inhibitor. Although to begin with a beta blocker like bisoprolol is not a disadvantage. The goal of the target goal of the ACE inhibitor should be tried to be reached. That means the target doses. Don't forget side effects like cough, dry cough, nausea, hyperkalemia, agranulocytosis, angioedema, hypotension, and renal function dysfunction. The next group are the angiotensin 2 receptor blockers. They also improve the prognosis. The head-to-head study in chronic heart failure done compared with ACE inhibitors did not show any doubt. So they serve as equally comparable alternative in case of ACE inhibitors, in cases where ACE inhibitors are not tolerated. Some special ACE inhibitors are approved for treatment of chronic heart insufficiency. They are losartan, valsartan, and candesartan. Important side effects are hyperkalemia, nausea, hypotension, and renal function dysfunction. Now, for beta blockers, only the substances that metoprolol, succinate, bisoprolol, and carvedilol improve prognosis and should be given. Nebivolol is only given in Europe, and in terms of improvement of patients with heart insufficiency, it has only been tried in patients above 70 years. Metoprolol succinate has better effect than metoprolol tartrate. The important effect of the beta blocker come into play after weeks of commencement of the treatment. Important side effects are bradycardia, AV block, tiredness, dizziness, headache, nausea, bronchospasms, Raynaud's symptoms, and if you have psoriasis, you can have worsening of psoriasis and also hypotension. So let's do the combination. The combination of ACE inhibitor or ARB with any of the above named beta blockers is recommended for prognostic reasons. When beta blocker is not tolerated in patients with advanced symptomatic heart failure with New York Heart Association class 3 to 4, the ACE inhibitor or ARB should be combined with an aldosterone antagonist. This is a class 1B recommendation. But the triple combination of ACE inhibitor, ARB, and aldosterone antagonist is dangerous because of potential of causing a hyperkalemia. So now let's talk about aldosterone antagonists. They improve prognosis. Spironolactone was examined in patients with heart failure, New York Heart Association 3 and 4, while the selective aldosterone antagonist, that is eplerenone, was only tried in patients with post-myocardial infarction and light heart failure. A combination of ACE inhibitor with ARB with aldosterone antagonist increases the risk of hyperkalemia. We do not advise a triple combination between ACE inhibitor, ARB, and aldosterone antagonist because of the danger of hyperkalemia. Important side effects are hyperkalemia, hyponatremia, gynecomastia, that is with spironolactone, but not for eplerenone. Now let's talk about digoxin. Well, it is actually seen as a symptomatic therapy. There's only a single randomized study, which is why the recommendation or evidence grade in 2005 was reduced from 1 to 2A. The recommendation goes only for patients with New Heart Association 3 to 4. In patients with heart failure and sinus rhythm, you are advisable to give the digoxin, but with low plasma concentrations. But irrelevance of the stage of the heart failure, in patients with atrial fibrillation, digoxin should be given for heart rate control. Side effects are all forms of heart rhythm disturbances, nausea, abdominal pains, headache, and some ophthalmologic disturbances. So the next group are the diuretics. Sorry, I speak German sometimes. They are actually to handle the symptoms, but they have no improvement on the prognosis apart from the aldosterone antagonist. The substance of choice, thiazide diuretics with or without potassium saving, loop diuretics. Combination can also be done as a sequential nephron blockade, but these are influenced by the severity of diuresis, renal function, and the serum potassium. Our patient already has a complete heart failure therapy. Bisoprolol 5 mg a day, candesatan 8 mg a day, eplerenone 25 mg a day, and toracemide 80 mg a day with hydrochlorothiazide from 25 mg a day, as well as amiodarone of 200 mg daily. The conventional heart failure treatment seems to be completely exhausted, and to increase the dosage of bisoprolol or candesatan, it does not look realizable because of the danger of hypotension. My question now is, which other medication therapy options are principally to be thought about now? Well, digoxin, as a symptom improving measure, digoxin can additionally be given. 2. Catecholamine or phosphodiesterase inhibitor, 3 inhibitor. Well, these substances are not indicated in compensated and stable heart failure. Levosimedan is a calcium sensitizer, which can be considered in this case. For example, as intermittent administration and as experimental treatment trial. The so-called pulse therapy with levosimedan is presently undergoing randomized studies. In anemia, the treatment of anemia in chronic heart failure with erythropoietin does not have enough data presently. A randomized mortality study with darbepoetin is presently going on. The recently published FAIR-HF, that's FAIR-HF study, showed that intravenous administration of iron led to a significant improvement of the symptoms, but we don't have any data on the mortality. Other substances are adenosine A1 antagonists, vasopressin receptor antagonists, recombinant natriuretic peptide mesitridine. These substances are presently being undergoing studies to check their relevance for acute cardiac failure, and clinically presently have no data. Aliskiren, the role of this renin inhibitor in chronic stable heart failure is also undergoing a randomized study. So which apparative therapy options do you really think is principally to be considered in this patient? A cardiac resynchronization therapy to optimize the contractions flow has already taken place. Different mechanical support systems like the ventricular assist device VAD are principally possible and should be discussed with the patient. The special pacemaker therapy with positive ionotropic effects, for example cardiac contractility modulation CCM, is presently undergoing an experimental study. So that's good. My question now is, what are the basic requirements for a cardiac resynchronization therapy, CRP, according to the European Society of Cardiology 2008 guidelines? Class 1A recommendation: when you have sinus rhythm, QROS more than 150 with left bundle branch block. Class 2A recommendation: sinus rhythm, QROS 120 to 150 left bundle branch block. Class 2B recommendation: sinus rhythm, QROS above 120 milliseconds but no left bundle branch block. Class 2BC, that is 2BC recommendation, is when you have a pacemaker recommendation irrespective of the QROS time. Another class 2A recommendation is when you have atrial fibrillation, QROS is more than 150 milliseconds and you have a left bundle branch block. Sorry, these ones I just said are for patients with chronic heart failure and have New York Heart Association 3 to 4. Let me repeat it again. Class 1A, sinus rhythm, QROS above 150 milliseconds, left bundle branch block. Class 2A, sinus rhythm, QRS 120 to 150 left bundle branch block, or for atrial fibrillation QRS above 150 milliseconds and left bundle branch block. That's a class 2A recommendation. Class 2B recommendation: sinus rhythm QRS above 120 milliseconds and without left bundle branch block, or when there's a requirement for pacemaker irrespective of the QRS time. Now, in patient with class 2, New York Heart Association class 2, the indication is a class 2B indication, and here it has to be sinus rhythm with QRS above 150 milliseconds and left bundle branch block. So thanks for that information. So according to all you have said now, what therapy options does this your patient has at his disposal presently? Well, heart transplantation. This option gives this patient a long-time good prognosis and a good life quality, and is presently the only next step option. Okay, you are thinking about a heart transplantation as a treatment option. What absolute and relative contraindications do you know to potentially list your patient for consideration? Well, here you talk about malignancies, chronic infection diseases, technical limitations. If there will be need for a combined heart and lung transplantation in old patients, and compliance of the patients. That's good. Now, let's talk about the tests you will need to do before you even apply for a heart transplantation in this patient. Which ones do you know? Well, you have to do infectious diagnostic. You have to do blood group and HLA typing, resting ECG, spiroergometry. You have to do echocardiography and coronary angiography. You also have to do a right heart catheterization. You have to do X-ray of the chest and see computer tomography of the chest, abdomen sonography. You have to do a gastroscopy with histological examination, coloscopy with histological examination, urological examination in men and gynecological examination in women. You have to do an ENT examination with X-ray of the sinuses. The patient has to also undergo dental and psychiatric examinations. Okay, let me tell you now. This your patient was able to undergo a malignancy test and an infectious test, and there were no signs of any of the above. The right heart catheterization showed the following parameters. The PA, systolic, diastolic, and mean was 44, 18, 27. PCV was 25. Right ventricle 45 to 12. Oximetry, central venous oxygen saturation was 52%. Aortic saturation was 96%. The PCV was overestimated because of the prominent V wave. Sorry, I speak German sometimes. PCV is PCW, that is pulmonary wedge, capillary wedge pressure. So how do you calculate the pulmonary vascular resistance? Well, you calculate that one when you get the difference between the mean pulmonary artery pressure and the mean pulmonary capillary wedge pressure, and divide that with the cardiac output, which gives the Wood-Einheit. How do you interpret this hemodynamic data related to the planned heart transplantation? Well, I can see there's a mild post-capillary pulmonary hypertension. For central relevance, we have a normal Wood-Einheit, in this case 1.8. When you have a Wood-Einheit above 2 to 3, you really need to do the reversibility test, because there's a threat to right heart failure of the transplanted heart when you do a solitary heart transplantation. If the wood iron height is above 5, or if the transpulmonary gradient increases to a value above 60 to 20 millimeters of mercury, we have a relative contraindication for the solitary heart transplantation, because the prognosis for a right heart failure, the transplanted heart, is likely. Okay, you have done all the tests and there are no contraindications for a heart transplantation. This patient was successfully listed and stays in the waiting list in the Euro transplantation. So what are the different stages for the urgency of a heart transplantation? I will tell you, you have high urgency, transplantable, and not transplantable. In the high urgency, the patients are in life-threatening situation, so they have to be favored in the transplantation. Relevant reasons are when patients are in intensive station, after exhaustions of all the alternative treatment modalities, including ventricular assist device and administration of catecholamine phosphodiesterase inhibitors, the patients are still in threat of organ failure. The patients in the urgency group, because of their life-threatening condition, they have to be admitted. They have to be considered above the elective group. Here we are not talking about patients that are in intensive station or with low dose catecholamine. Then the elective group, which are the transplantable group, these patients met the criteria to be listed in the list, in the waiting list for heart transplantation, but they are not in the urgency or high urgency group. Then the non-transplantable patients are those patients that are in the waiting list but have one contraindication to transplantation, for example, an infection. So when you are getting the patient consent on transplantation, what do you need to tell the patient about the prognosis after transplantation? Well, according to the data of the International Society of Heart and Lung Transplantation year report from 2009, the 1-year survival rate of patients, according to the register between 2001 to 2007, was 90%, and 5-year survival rate was 70%. Thank you very much.